دكتور عبد الحميد تسلم ايدك، يعني حالة صعبة ويعني ماشي خطوة خطوة وشرحت لنا ووضحت لنا ايه الانديكيشن اول انك تعمل ديب سكلكتومي مع فيكومالسيفيكيشن، وليه انت بتزود الخطوة بتاعت الترابيكيلوتومي at the end of surgery.
You know, Dr. Yahya, that glaucoma is not a single attack. You should prepare yourself بكل surprises as regards الهيلينج بتاع العيان. Still الهيلينج can affect الليك اللي احنا بنحافظ عليها بالاولوجين. Still الهيلينج can affect الكاتنج بتاع الترابيكيلوتومي because they are leaves and the leaves its cut ends can heal still. So you should have a lot of weapons in order to reach by your patient to a very safe level and maintain of intraocular pressure. So adding a step is not something you should not adopt. You should adopt the whole weapons during your surgery. I don't do penetrating trabeculectomy. This patient was an open angle patient and the seepage was nice as you have seen, and I could have done only the non-penetrating issue. But I would like to add the trabeculotomy step to patients, especially who are elderly. The healthiness of the Schlemm's canal and trabecular meshwork is at its best performance at young ages. For example, open angle with steroid-induced, open angle with developmental glaucoma, open angle with congenital glaucoma. You'll find a difference in the rate of seepage, marvelous. In young age, the seepage is marvelous. Still, this seepage was not optimum, so that's why I added the step of the trabeculotomy.
Perfect. When you choose to do a combined surgery on basis of the intraocular pressure control or the optic disc health, what is your indication to combine the surgery?
The main indication is the angle. The angle, if it's a narrow angle, you are not able to attack this angle alone by itself. If you have a narrow angle, you should discriminate or define it as pupillary block, which will benefit totally from lens surgery.
Right.
However, in our population, the plateau iris shares with a good portion in narrow angle classification. I see a lot of narrow angle with plateau and pupillary block. So in these cases, the lens surgery is not enough. And as you know, it's a narrow angle with synechial closure or oppositional closure. If synechial closure, the trabeculotomy will work very nicely. And if you have a 360-degree synechial closure, this limited trabeculotomy is not enough. You can extend your management to 360-degree trabeculotomy with Prolene-guided
GAT.
Yes. No, the GAT is from inside. It's gonio assisted. This is the same platform doing a Prolene pushing in the canal of Schlemm, retrieve it from the other side through an external approach.
And you pull it back.
And you pull it. You can pull it by pulling the two ends of the Prolene, or you can just do a trabeculotomy and retrieve the end of Prolene from inside in order to maintain the membrane and keep your surgery closed system.
Thank you.
عملنا تسمين من غير الترابيكيلوتومي، هل النتائج هتبقى أقل؟
If it's open angle, it will be limited because of the age. If it is narrow angle, it's mandatory because you will find no seepage. If you include trabeculotomy in narrow angle, you should treat a case with synechial closure and more than 180 degree and only pupillary block.
But open angle is more common. We see more. Yeah, it's more common.
No. أنا بختلف مع حضرتك بالحكاية دي، لأن أنا بشوف narrow angle أكتر من open angle. And if I have a patient with fresh patient with open angle, I would go for SLT before doing even the prescribing eye drops.
Yes.
عبد الحميد ممكن نسألك سؤال؟ انت استخدمت كل الويبونز بتاعتك، هل ما عندكش حالات زي كده فيها هايبوتوني؟ هل ما بتخافش من الهايبوتوني؟ انت عملت نون بينتريتنج مع ترابيكيلوتومي مع واتس اباوت، ليه استخدمت كل اسلحتك؟ ليه ما خليتهاش لمرحلتين مثلا؟
في اسلحه ثانيه لسه ستيل في اسلحه يا دكتور علاء.
أيوة،
في نفس
ماشي.
العيان في نفس العيان بنفس البروسيدور اللي احنا عملناه، لو البيشنت has rising intraocular pressure post operative and I can put him in a YAG laser goniopuncture. With the YAG laser I can define this trabeculodescent membrane I maintained during the surgery and puncture it with the YAG laser. So this is an extra weapon. And if this is not enough, I can do in the post-operative period with a spatula ab interno puncture of this membrane. So I have a lot of still of weapons.
يعني
I'm
أنا
preparing the patient.
اتس اوكي تفكيري العكس الهايبوتوني، يعني انت استخدمت زياده عن
hypotony
اللزوم.
خالص. No hypotony at all, because I reach a level that's equivalent to the normal trabecular meshwork function, which is about 6 to 8 millimeter mercury.
طيب شكرا عموما، يعني عمليه عظيمه وشو رائع يعني، شكرا جزيلا.
شكرا.